Good morning. My name is Alazy Victor, and I will be your moderator for today's webinar, Session 2, Antimicrobial Stewardship Strategies for Implementation. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end of the presentation. You can pose a question in the chat box. Please make sure to send questions to all attendees. At this time, I'd like to introduce Carrie Barton with the Massachusetts Department of Health. Carrie, please press pound 6 to unmute your line.
Hi, good morning. It's my pleasure to introduce Dr. Shira Doron and Dr. Beaulac. Shira Doron is a physician in the Division of Infectious Diseases at Tufts Medical Center. She has been the physician head of the Antimicrobial Stewardship Program there since 2005 and is also the Associate Hospital Epidemiologist. On a national level, Dr. Doron serves on the Society for Healthcare Epidemiology of America Antimicrobial Stewardship Subcommittee and the Infectious Disease Society of America Antibiotic Stewardship and ID Leadership Working Group. Here in Massachusetts, Dr. Doron has been involved in several statewide initiatives to improve the care of patients with suspected or confirmed infection. Dr. Doron has numerous publications related to antimicrobial resistance and stewardship. Kirthana Beaulac is a pharmacist who trained at Massachusetts College of Pharmacy, completing postdoctoral training in infectious diseases at Hartford Hospital. She is the pharmacist head of the Antimicrobial Stewardship Program at Tufts Medical Center, as well as the infectious disease pharmacist for the institution. Dr. Beaulac is involved in the Massachusetts Society of Health System Pharmacists, the Council of Boston Teaching Hospitals for Pharmacist Education, and the Society of Infectious Disease Pharmacists. Her research focus is in methods of optimizing antimicrobial use. Thank you both for speaking today.
All right, thank you for that introduction. So, again, my name is Shira, and today we are going to talk to you today about antimicrobial stewardship and specifically some strategies for implementation at your specific institutions. Before we jump right in, I just want to throw out a quick polling question about how you feel about antimicrobial stewardship. So, with respect to antimicrobial stewardship, how do you feel that your facility has a program in place, has a feasible plan to implement a program, or has little, if any, program or plan in place? Jennifer, could you please open the poll? And please enter your responses in the bar on the right. All right, the polling has now closed, and in just a minute we'll have our responses about where everybody's at in terms of having a stewardship program. All right, so it seems like a dead even split. There's 29, fewer respondents feel like they have a program in place, but it's almost even that kind of across the board of where everyone's at. So it seems like we've got a good mix of people. So today we're going to talk about some strategies for implementing antimicrobial stewardship. So by the end of today's webinar, we hope to review the landscape of antimicrobial use and resistance in long-term care, as well as the regulatory requirements surrounding antimicrobial stewardship. We hope that you'll be able to define the elements of a successful stewardship program, to be able to outline the role of each member in the care team carrying out the goals of stewardship, and lastly, to be able to describe examples of antimicrobial stewardship interventions that have been successful at other long-term care facilities. So let's kind of focus on the problem as a whole. This may be preaching to the choir, but many of you know that there's a lot of patients with infections in long-term care facilities. On average, there's millions of patients that are diagnosed with infections in long-term care each year, with a total of 1 to almost 8 million patients each year in nursing homes requiring or being diagnosed with infections. And the result of that is a lot of antibiotic prescriptions. It's been estimated that between 50 and 75% of long-term care residents in the United States get at least one antibiotic prescription each year, which is an enormous population of patients. When you compound on that the fact that it's been estimated that 25 to 75% of those systemic antibiotic prescriptions and 60% of topical antibiotic prescriptions are considered either inappropriate or unnecessary. So this is a huge number of prescriptions that are being, antibiotic prescriptions each year, with a large proportion of them potentially being inappropriate or unnecessary. And going back to the original topic of the fact that so many patients have infections, millions of patients have infections, that's based on the assumption of they have a diagnosis of infection. And we have to kind of question, is this an accurate diagnosis? And then did all of those diagnoses actually warrant antibiotic prescriptions? So, we have to wonder why are there so many inappropriate or unnecessary antibiotic prescriptions? Some researchers have kind of looked into this and clumped it into two major buckets. Some issues are workflow related. So very often the diagnosis or management of an infection needs to be done in the absence of a licensed independent practitioner like a physician, NP, or PA. And even if they are physically present, they often have limited time to be able to fully evaluate multiple patients without, readily available night and weekend access. Additionally, most long-term care facilities lack the institutional prescribing guidelines, potentially, access to contemporary references, and have little to no prescribing oversight that would help guide them in improving their practices. And lastly, many long-term care facilities lack access to ID specialists or specialized diagnostics that would help them in determining if a patient truly has an infection and if they truly need antibiotics. And then, aside from that, there are some cultural issues in our prescribing practices that lead to this overuse of antibiotics. Some patients who seem really old and frail, you may think, well, there's no room for error here. We have no opportunity to get it wrong. We definitely have to treat this person with antibiotics in the rare instance that it could be an infection. The next item that was identified was demanding families, and this is something that many of you even self-identified as an issue in the previous webinar, that families often view institutions as potentially negligent or undertreating their family members if they assume that their family member has an infection. And that really goes back to educating the family about what an infection really is. And lastly, there's always in our litigious society concern that if, for whatever reason, the clinician thinks that there's not a true bacterial infection, that antibiotics aren't needed, but then, something could happen, there is that fear of litigation. So prescribers tend to over-prescribe rather than under-prescribe just to protect themselves from a legal perspective. So there's a lot of reasons that we have a good amount of over-prescribing of antibiotics, and although it seems like these are kind of relatively reasonable reasons, there are significant consequences to the overuse of antibiotics in this population. We know that antibiotic exposure or recent antibiotic exposure is the single greatest predictor of developing a multi-drug resistant infection going forward, and this has been proven in various populations and various settings that the use of antibiotics causes antibiotic resistance later, and that can be in the population as a whole, or it can be even in that same patient. So we really need to change the paradigm in thinking about how we use antibiotics and really what are the risks associated with maybe being a little bit judicious with your antibiotic prescribing. So now I'm going to kick it over to Shira, who's going to talk a little bit about the 4 elements.
So, how are you, working in a long-term care facility, supposed to implement a stewardship program? We've been spending a lot of time on the concepts and why stewardship is important. But now let's get into the nitty-gritty of implementation. And the first thing you should do, if you haven't done this already, is to go to the CDC website on the core elements of antibiotic stewardship for nursing homes. And there are a lot of resources on that site that you can use for specific tools for stewardship implementation. But we need to start with these core actions that every stewardship program should be taking before they even begin. And the first thing you need is a leadership commitment. You will not succeed in implementing stewardship unless you can demonstrate the support and commitment to safe and appropriate antibiotic use in your facility by the leaders who will need to be the ones that are allocating the resources to this initiative. And accountability. Who is the physician, nurse, pharmacist, who are going to be the leads responsible for promoting and overseeing antibiotic stewardship activities in your facility? And again, they do need to be given some dedicated time and incentive to do this. Drug expertise. It's important to establish access to a consultant pharmacist or other individuals with experience or training in antibiotic stewardship for your facility. And then action. Once you've done those things, it's time to implement at least one policy or practice to improve antibiotic use. And that can be really small because one success will lead to another, Let's start with one. It's important, though, that when you roll out that one action, that you then track it. You need to monitor at least one process measure of antibiotic use and at least one outcome from antibiotic use in your facility. I did something. Did it work? Do I need to tweak it? And what can I do next that can further my success? And reporting, providing regular feedback on antibiotic use and resistance to the prescribing clinician, nursing staff, and other relevant staff. Because if that quality improvement project happens in a vacuum, you're not engaging your providers to further that goal. And finally, education. Education is such a huge part of what we do here at Tufts Medical Center, providing resources to clinicians, to nurses, residents, and families about antibiotic resistance and opportunities for improving antibiotic use. So what are the ingredients for a successful program? We're going to go through 5 key elements, I think, that we think are most important to create a successful stewardship program. And those are culture change, provider education, the use of appropriate metrics and benchmarking, the use of the microbiology lab, and the use of technology and informatics. So starting with culture change. Here at Tufts Medical Center, when we rolled out our program well over a decade ago, we did not just do that without getting buy-in from the key stakeholders. People were invited for coffee, lunches were brought in to various conferences, and throughout the institution, people from the leadership down to the attending physicians, down to the residents, were all queried for their thoughts and opinions about the idea of stewardship and educated about its importance. And only once we started to achieve that buy-in did we begin to implement our actions. So it's important to be cognizant of, especially physicians, reluctant to give up autonomy. By nature, physicians aren't going to want to be told what to prescribe, but if they can understand that there are experts who have more knowledge about appropriate use of antibiotics and can provide them with assistance, then that's a lot better received. If your team that you create is multidisciplinary, that's going to be much more effective across the various roles that are going to be affected by the program, so that you're champions. If you're seen more as providing a helpful or teaching service than as being the antibiotic police, that's incredibly helpful. And there are a lot of concepts of behavior change theory that can be used to more effectively roll out initiatives throughout the world of quality improvement. And finally, soliciting feedback often. Every time you make a change, you want to make sure that the end users can appreciate that change and see if there is any feedback that you can get that can help to improve your program. So this is an example of culture change, feedback, and education. We conducted a study where we evaluated our program with house officer feedback. So the first thing we did was we surveyed our residents in 2008 about the program, which had been around for 4 or 5 years at that time. Based on the feedback we got from those residents about the existing program, we made some changes to the program. We enhanced the training that the residents received at orientation about stewardship. We changed the antimicrobial order form that we were using at that time that had specific data elements that had to go in before your patient could get an antimicrobial. And we implemented something called ASP Question of the Week, our stewardship team's Question of the Week. Every week we actually had a teaching point that went out by email to all clinicians. And those emails might be about how you utilize the stewardship program, things about paging and hours, and they might be about how you choose antibiotics for your patient. After doing that, we repeated the survey with almost the same questions in 2010. And so what you can see is that if you look at the top box there, this is pooled data from 2008 and 2010 together. Have you ever had an interaction with the stewardship program in which they? And so it's interesting to see that a third of respondents said that the ASP had reminded them of a patient allergy when they were otherwise, the long version of the question is, when I was otherwise going to forget. The ASP reminded you to adjust for renal function 3/4 of the time when they were otherwise going to forget to do that. And the ASP has prevented them from making a medication error over a third of the time. Over a third of the respondents felt that the ASP had prevented them from making a medication error. And if you look at the differences between the responses in the 2008 versus 2010 poll, you can see that some of the responses were similar from the early to the late time period. How important is the ASP in fighting against antimicrobial resistance? 3/4 felt that it was. The vast majority thought stewardship was important in the containment of healthcare costs and of prevention of medical errors. Interestingly, there's a little bit of an increase, but not a ton, in the percentage of respondents who felt that stewardship procedures were presented during orientation. And the fact is that 100% of those respondents did receive stewardship orientation. So this is one of the things that taught us that orientation is not a good time to teach people about stewardship procedures, and we do it differently now. But have you ever been confused about ASP procedures? That number went down significantly. And how has your educational experience been with ASP? That number went up significantly, and we attribute that to the changes that we made in response to their feedback. Education, as I said, is something that makes up a very large proportion of our daily work, and really every interaction that we have with clinicians all day long is an education opportunity. Keeping in mind that medical school education is really lacking in the concepts of stewardship, we really assume that the people that we're talking to, especially the new interns, have no knowledge of these concepts at all, and so we start with the real basics. We focus on the concept of colonization versus infection. Every single day we have conversations about that, and that is huge, and we're going to actually devote an entire webinar, the next one, to this concept. It's called the approach to the patient with respect to UTI, but we're going to really talk about the concept of colonization versus infection in various sites. Community-acquired versus hospital-acquired infection. That's something that we talk about every day as well. Does this patient truly have risk for multi-drug resistant organisms, or can we use a narrower spectrum antibiotic even before we get our culture data? De-escalation is so important in stewardship. And that's the idea that when you start antibiotics, you may start broad. You may start with some uncertainty about whether the patient even has an infection. And so once you get your culture data, or once you have more clinical information, you need to de-escalate to the narrow spectrum agent that covers what you've grown. And in the next bullet, the early discontinuation because you've decided that the patient doesn't have an infection anymore. Could have an infection, but it is now completely resolved, and that is actually the time to discontinue. Many people will say, but my patient is getting better on that. I don't want to mess with success, and that is not a good way to be prudent with antibiotics. And then there's a lot of, but that's what he or she was transferred here on, and this is really relevant to long-term care, obviously, because patients come on antibiotics. And for us as a tertiary care referral center, a very large proportion of our patients come from other institutions on something, but that transfer is an opportunity to reevaluate the patient's care and get them on what's best for that patient. So we encourage you to consider surveying your clinicians to gauge their knowledge, and here's a survey that we carried out. This was published in 2014, and this was a multi-center survey of healthcare practitioners about their knowledge related to carbapenem-resistant Enterobacteriaceae, which is highly resistant gram-negative. And you can see that, knowledge scores were relatively low, but actually what we found was that the earlier in their training the physician was, the more they knew about highly resistant gram-negative infections. So actually those who had been in practice for more than 10 years had the lowest knowledge score. So something to keep in mind.
So another important key to success is using metrics, measuring how you're doing and being able to track if you're doing well, what you need to improve on, and there's a lot of different metrics you can use to evaluate this. Here I have listed a couple of the common ones. You can look at your overall drug cost, how much are you spending. Those can be normalized in a couple of different ways, looking at defined daily dose, like how much total antibiotic are you using. You can normalize it by patient days, by how days of therapy, length of therapy. You can look at a snapshot of, at any given point, what proportion of your facility is receiving antibiotics. You can look at trends in resistance and trends in C. diff. I'm not going to focus too much on this because we have webinar number 6 largely focused on tracking and trending metrics. Another big tool is leveraging your microbiology lab, because they have a lot of useful tools that can help you decide whether or not you should be using certain antibiotics. At our institution, we do a couple of rapid diagnostics, and our use of the rapid flu swab was able to decrease the number of antibiotics or the amount of antibiotics that we use, because once you know that somebody is presenting with flu, you know that you can kind of rule out a couple of bacterial infections. And we were able to use that as an opportunity to improve our antibiotic prescribing for respiratory infections. Additionally, your microbiology lab can work with you on developing an antibiogram, and ideally, you can even get really fancy with it and do unit-specific antibiograms, disease-specific combination, looking at 2 different drugs together. Again, I'm going to kind of not touch on this too much because we'll circle back to this in future webinars. But just know that there's a lot of opportunities to improve your prescribing based on data that you can pull from your microbiology lab. Here I have an example of an antibiogram for those of you that have never seen one before. Okay, so here we have all of the organisms that our hospital has grown over the course of the year, and here we have all of the antibiotics that we have on formulary that we're routinely testing susceptibility for. So if you think your patient has an E. coli infection, or you want to empirically cover for E. coli, you can look across the row and identify that which antibiotic is most likely to be effective for an E. coli infection. And you can do that for whatever infection you think your patient might have. And aside from using the microbiology lab, There's a lot of technology and informatics that can also supplement your stewardship program. If your institution has an electronic health record, very often those have embedded query functions that you can use to run reports or potentially even build rules to alert you when a certain thing happens. So if you want to know how many of your patients are on spectrum antibiotics or on high-cost antibiotics, or there's a lot of tools that you can build into your electronic health record if you have one. Additionally, there's a lot of clinical data support systems or clinical decision support systems that are also known as data mining tools. What they do is they look at all of it's a third-party program that can look at your data and your electronic health records and come up with information that's actionable for you. It builds in some clinical decision support to say, hey, this person has negative cultures and has been on antibiotics for 5 days. Maybe you should look at them and perhaps think about an opportunity for intervention there. There's a few apps out there that can help with the clinical decision making, is determining whether or not a patient does indeed have an infection, or if they do have an infection, what is the most appropriate antibiotic for that situation. There's also a couple of electronic resources that provide a lot of drug information, like LexiComp or clinical pharmacology, UpToDate. These electronic resources provide fantastic, accurate, up-to-date information that sometimes some other tertiary resources can be lagging on. And lastly, listservs are a great opportunity to bounce ideas off each other, get feedback from your counterparts at other institutions. There's a ton of great information on listservs that are out there, and we really encourage you to be active and participate in various listservs. Here's a screenshot of what some of the clinical decision support systems look like. And here what you see is that, there's rules that are firing for patients to say, hey, look at this person, they have VRE, or, this person has, all the different various cultures that are flagged as positive, and it gives an opportunity to have targeted surveillance. And then conversely, you can use similar electronic tools that can query your electronic health record to keep track of your various things like your C. diffs, which are, important for reporting.
So what can you do? We've given you a lot of examples of tools that can be used and strategies. And I realize that many of you don't have electronic health records, so there's nothing to query. But here are some things that everybody on the call should be able to do, and we're going to break it down for you by role. So long-term care facility administrators, what can you do? Well, you can establish those multidisciplinary teams to address antibiotic stewardship and optimal drug use. You can make sure that they are coming up with protocols outlining the appropriate circumstances for use of antibiotics. Again, we're going to talk about that a lot more in the next webinar. You can review antibiotic culture data with your champions to look for trends that suggest that you have a worsening resistance problem. Because if you do, that's something that you need to be aware of and doing something about. You can make sure that there are protocols in place to ensure that cultures are checked when they come back, and the antibiotics are adjusted according to culture results every time. And you can make sure that there are programs in place for periodic review of antibiotic utilization. If you're a long-term facility provider, you should be obtaining cultures whenever possible when starting antibiotics and checking the results and adjusting antibiotics appropriately to the narrowest spectrum agent possible. Avoiding the use of antibiotics for colonization, for contamination, and for viral infections, and keeping that duration as short as possible. Those days of finish the entire course, even if you don't feel like you have an infection anymore, that's the old days. We're in a new scary time where the durations actually need to be kept as short as possible. You should be taking care to effectively communicate regarding any pending lab results and any plan for antibiotics and what the follow-up plan is. Those details need to be very, very clearly communicated, and I encourage you to develop standardized intake tools so that all of that information comes over with new residents or residents that have gone to the hospital. Nurses at a long-term care facility can be familiar with current protocols for testing and treatment of presumed bacterial infections, can educate families and residents that many respiratory infections are caused by viruses and do not require antibiotics, that many times what's suspected to be a UTI is not, and that there are appropriate indications for testing and treating suspected UTIs, should be following advanced directives for limited treatment. And in addition to things like DNR and do not hospitalize, do not give antibiotics is a very appropriate directive for patients at the end of life. And to follow up with referring facilities regarding pending lab results. Prescribers. Prescribers can encourage the use of screening tools and protocols in order to decrease the use of unnecessary antibiotics, can educate their fellow clinician staff and family members on the appropriate use of antibiotics, and can implement measures to reduce the need for treating with antibiotics. And those include some infection control things like avoiding the use of indwelling urinary catheters. Once a patient has a urinary catheter for 21 days, they have about a 100% chance of having a positive urine culture. Once somebody who's a prescriber sees a positive urine culture, there's a compulsion to treat that positive urine culture, but that doesn't actually represent infection. Maximizing immunization levels is going to decrease infection, and things like decubitus ulcer prevention obviously are going to help to avoid infection and less use of antibiotics. Long-term care pharmacists can review antibiotic utilization and, where possible, appropriateness, can identify opportunities for improved prescribing and discuss these at QI meetings, can educate physicians and nursing staff about targeted antibiotic use using narrow-spectrum agents based on culture results, can prepare updated and easily accessible protocols, can apply pharmacokinetic principles to vancomycin dosing and monitoring. Vancomycin is obviously really difficult to dose. And can make sure that we avoid administration of divalent cations like iron, magnesium, calcium, and zinc, which a lot of our elderly patients are on, not giving them within 6 hours before or 2 hours after fluoroquinolones because that decreases their efficacy. Can ensure prescriptions are compatible with allergy history and encourage use of the oral route for highly orally bioavailable drugs, which is a big cost-saving intervention that can be very effective to kick off your stewardship program. What can facilities do together? They can develop communication tools to share critical information between acute and long-term care facilities when patients are transferred back and forth. Like I said, a standardized intake form can be really helpful with that. That form should have on it culture results, pending results, what treatment was initiated, when, why, and the planned stop date, what isolation precautions the patient was on, what immunizations the patient has already had, and if there's a history of C. diff or other multi-drug resistant organisms. Facilities should ensure that the contact information is provided so that providers can communicate back and forth with each other on patient history and pending test results, and establish cross-facility teams to address infection prevention and antibiotic stewardship. If acute care and long-term care work together and collaborate on these things, everybody wins. So we're going to ask another question, and we want everybody to please respond. Of the strategies just discussed, the one that seems most feasible at my institution is A, change prescribing culture, B, roll out provider education, C, develop treatment algorithms and protocols, D, implementation of family education programs, E, use of technology and informatics, F, implement a plan to look back at cultures and antibiotic prescribing, or G, create or improve communication infrastructure between facilities. So, Jennifer, will you please open up that polling question? And we'd like everybody to say which one seems most feasible. And, I think that this will be useful to us both in terms of figuring out what the low-hanging fruit is and also, what things just, if there's a consensus that something's not feasible, then that's not where you want to put your resources and your efforts. So go ahead and respond. A, changing culture. B, prescriber education, C, treatment algorithms and protocols. Okay, and D was implement patient and family education. We're waiting for the results here. E, technology and informatics. F, plan to look back at cultures. And G, communication infrastructure. So let's see what people felt was most feasible. So it looks like the largest percent, so we have a tie between treatment algorithms and protocols and implement a plan to look back at cultures and antibiotic prescribing. So that's good. Those are both actually pretty difficult things to do. And so if people feel like they could do that, that's terrific. Changing culture, yep, I see that that's a really tough one for people. And as expected, use of technology and informatics got the lowest score, and that's no surprise. Creating and improving communication infrastructure between facilities, it's disappointing that people feel that that would be so difficult, because I really feel like that is so key to making sure that that patients get the course of therapy that is intended, to making sure that patients who come from the hospital to long-term care don't end up on antibiotics that were perhaps prescribed based on a pending result. So there's it sounds like we have a lot of work to do to help with some of these concepts still, and that's what we're here to do. Okay. So we're going to ask another polling question, and basically the same question. Which one do you think is most challenging? And let's just make sure, Jennifer, you can just open that right up, because it's the same questions, and let's just make sure that that we understand that. I think that we're going to.
Yeah, so the first one was which one was the most feasible, and now the second question asking which one is the least realistic for you.
I think we're going to see a reversal here, but let's make sure so that we can help you. Jennifer, you can open that up again. And we just want to make sure that we can, in our next webinars and in resources that we provide to you, that we're helping you target your biggest challenges. And so I anticipate that we'll see, again, use of technology being the biggest challenge. Perhaps here we have G should be
create or improve communication infrastructure between facilities. So
there's a problem on the slide, but it is there in your poll. So we may see that we have that G is a challenge, which was a little bit unexpected for us. I think we expect technology to be a challenge. Let's see what people say here.
So yes, culture is the big winner. That changing prescribing culture is a challenge, and that is not unique to long-term care. That's a problem across every area where stewardship is being implemented. Is that changing prescribing culture is a real challenge.
I can tell you that I've been to many acute care facilities that don't have stewardship, and they say the same thing. I don't feel that I can change the culture. My physicians want autonomy. They do not want to be told to follow a protocol and what to prescribe. But I can tell you that at the acute care centers that do have successful stewardship, we all started that way. We all started with the same personality types and physicians where there was an issue of autonomy. And if you chip away at that culture, you will see improvement.
All right, so next we're going to move on to kind of moving from, some blueprint ideas. We've just kind of given you generalities of things you can do, and turn the blueprint into, build a building, make it happen. And, I'm going to give you a couple of examples of some long-term care facilities, what they've done and the successes they've had. So first, I'm going to talk about just some low-hanging fruit, easy things that can be done for you to improve antibiotic use in your facility. So as Shira mentioned, there's a couple of antibiotics that are highly orally bioavailable. That means that the amount of drug that's in your body is pretty much the same whether you give it by mouth or whether you give it IV. So if you can avoid giving an IV, why not? That decreases, discomfort for the patient. It improves their ability to be more mobile. It decreases their risk of a line infection. So those are all reasons that we try to get people on oral antibiotics as soon as possible, assuming that they can absorb things by their gut. So things like fluoroquinolones, linezolid, metronidazole or flagyl, clindamycin, Bactrim and fluconazole are all highly orally bioavailable, and we try to get people onto orals as soon as possible with those. There's other things that you can do with antibiotics in terms of dosing them in a way that can optimize the exposure that the patient has, and then, to a certain extent, minimizing the amount of drug that you need to use. So making sure that you're using the right dose for a patient's age, their kidney function, and their weight can sometimes prevent a med error or prevent overdosing or underdosing a patient. Additionally, making sure that you're using the right dose for the organism that's causing an infection, using the right dose for the right site. We know that antibiotics get into the urine really, really, really well. They concentrate there. So sometimes you can get away with using less antibiotics to get into the urine, knowing that it's going to really concentrate there. Comparatively, if you have a really hard-to-treat infection like a central nervous system infection, getting antibiotics into the brain can be really challenging, and sometimes you need to use extra antibiotics to make its way in there. And then lastly, the use of extended infusions of beta-lactam is an opportunity to use less antibiotics per day, but get the same bang out of the drug. So the use of extended infusions, we'll talk about in a future webinar, but that could be another opportunity to optimize the way you're using antibiotics. Next, I want to talk a little bit about a program that was implemented in England, but it's still very relevant. It was an antimicrobial stewardship tool that was implemented in many nursing homes. So there were 30 nursing homes that participated in this study, and it was a mix of small, local, independent nursing homes, as well as some large corporate nursing homes, with a total of 1,832 beds. So this is a really big intervention. And what they did is they implemented this two-part tool, which was a pre-printed form that nurses would use, and different centers were randomized to use the tool or to not use the tool to see if it was able to improve antibiotic prescribing. And there were a lot of residents that were evaluated. Over 1,600 were evaluated pre and post intervention. So the tool itself, I think, is really probably what's most useful to use, and what's in the tool. So it was a nursing-driven checklist to just evaluate patients at two different time points. So the nurse would evaluate at the time that antibiotics were being initiated for these 6 things. So they would look to see, yes, no, are clinical signs and symptoms present for infection? Has the resident been examined by a physician? Yes, no. Is there a diagnosis or site of infection that's documented that you think you're treating? Have any appropriate clinical specimens been sent? Have things been sent for culture if that is appropriate for the suspected site of infection? Making sure that the antibiotic is appropriate for the indication, for the patient's allergies and comorbidities. And lastly, making sure that yes, no, were the antibiotics initiated promptly upon the diagnosis of this infection. So there's no mandatory requirement that everything had to be yes, but the big intervention here was just the process of implementing this checklist and having somebody do that evaluation of whether these things were present. The second part of the tool was a look back. So this was at around 48 to 72 hours after antibiotics were initiated. The nurse would again do a second checklist. Now this checklist was to, yes or no, was this is the checklist being done the second time? It looked for whether or not a stop date or a planned review date was documented, or are the antibiotics just going to go on indefinitely? It looked for whether or not the resident was re-examined by a physician and whether or not cultures were reviewed. And lastly, the last thing on the checklist was looking at whether or not there was an assessment and documentation of did this treatment actually work? Is the patient better after being on antibiotics for a few days, or is there no comment? And being able to at least comment that, I initiated antibiotics, the patient is better, is an important part of being able to justify antibiotic treatment. And again, just like the first part of the tool, there was no requirement that every single item had to be a yes, but conversely, just the process of having somebody go in and evaluate these things kind of was just a small prompt to really think about whether or not antibiotics were appropriate in both of these time points. Now, about half of the centers used this tool, and about half of the centers were used as a control to see, is antibiotic use improving anyway? And what we found is that in the centers where there was no tool implemented, antibiotic use actually did show a significant increase. Even though the baseline was lower than the intervention group, they actually showed, on 3 DDDs per 1,000 patient days, they actually showed a significant increase in their antibiotic use. Conversely, in the area where this tool was being used, they were able to see a decrease that was statistically significant from almost 70 DDDs per 1,000 patient days down to 66. So one could argue that although the magnitude of difference doesn't seem like that large, you would think that if this program wasn't in place, the rate would be even increasing. So we were able to see a significant decrease in an era of increasing antibiotic use with just the simple nurse-driven checklist of, making sure that all of these elements are in place. Another successful antimicrobial stewardship program was carried out in a long-term care facility, a nursing home that was done at a VA in Cleveland. So this service, called the LID service, or the Long-Term Care ID service, was carried out at this long-term care facility that was attached to an acute care VA hospital. So there was an ID physician and a nurse practitioner that would come from the acute care hospital to the long-term care facility 1 day a week to do stewardship consults. And then we're also available the rest of the week via telephone, and they had a unified medical record, which is fantastic, but maybe not realistic for everybody. And they were able to provide telemedicine assistance for the rest of the week. This service of the ID physician and the NP saw about 7 patients each day that they came by and fielded about 5 to 10 calls each week. And, a third of the consults were really just a single visit to evaluate the patient, and many of these phone calls did not even result in having to visit the patient. The rest of the consults required a little bit more than 3 visits, but often did not need to be seen by the LID service that many times. Now, with this minimal input of resources, we were able to see that although antibiotic use in the attached VA hospital, where nothing had changed, was kind of essentially flat, there was a dramatic decline in the use of both IV and oral and overall antibiotics with the implementation of this relatively low resource intervention of just having somebody swing by 1 day a week. And then conversely, the hospital was seeing a dramatic increase in their rates of C. diff, but the long-term care facility was able to turn that around and actually decrease their rates of C. diff. So Shira just
described is an example of acute care providers working with long-term care facilities to provide services. Briefly going to just give you an example of a collaboration like that that Shira and I were involved in, and this was at New England Sinai Hospital, which is a long-term acute care facility. So Shira and I served as private contractors to Sinai Hospital, and we worked with leadership. The ID consultant was on board with the concept. The infection preventionist was part of our team, and the pharmacy director. Now, what they were already doing was they were requiring an end date and an indication for every antimicrobial order, and the pharmacy would not release the drug without those things. But what we did was we added a list of the great 8 antimicrobials, the ones that we thought had the biggest impact on resistance and cost. Shira and I, and we had a couple of other physicians involved at various points in this project, we intervened from off-site Monday through Friday. Again, here we had the benefit of an electronic medical record like the VA nursing homes do. And so we were able to log on and generate a report daily of all patients who had been on antimicrobials for at least 7 days. And we reviewed those patients' electronic medical records. We made recommendations to the providers by email, and we also provided some clinical pathways for them to use to follow for specific diagnoses. We analyzed the data from this intervention from April 2011 through March 2014. We made 885 recommendations on 734 patients, spending approximately 1 to 2 hours per week reviewing cases and providing recommendations remotely. So again, not a huge investment of time, and since we were paid by the hour, not a huge investment of money. The residents were a mean age of 68 years, and the median length of stay for these residents was 56 days. So these are the types of infections, and what was interesting is that actually the largest number of infections recommendation was colitis, in other words, C. diff colitis, because that institution had a huge C. diff problem and many, many patients on C. diff medication. And not surprisingly, UTI was the second most common. There was a lot of osteomyelitis. That's the reason the patients were there were for long-term antibiotics. And you can see the others. Here is the breakdown of cases in which we agreed with management, so 45% versus didn't agree and made a recommendation. And when we agreed with management, often we did have other suggestions like labs that needed to be checked to ensure that there was no toxicity. And so of the ones where we didn't agree and made a recommendation, overall during the period that we're showing you here, the recommendations were followed in about just under 50% of the time. And the types of recommendations, the most common recommendation we made was to stop antibiotics altogether. Your patient does not have an infection. A lot of times what we wanted was more information, and that gets back to that interfacility communication and intake form, because a lot of times we didn't have the information from the transferring facility with which to make a decision about whether the antibiotics were appropriate, and this is a big number. We sometimes recommended an ID consult. We made some recommendations to change and de-escalate antibiotics, shorten, prolong, and sometimes to change the dose. And so what's interesting in getting back to the idea of culture change is that the percent recommendations accepted increased over the course of the time that we were intervening as providers became more and more confident with our recommendations and appreciated what we had to provide. Here's the intervention here. Over time, you can see that there was a sharp decline in C. diff rate at the time, right after the recommendation, and then a slow decline thereafter. And then this is antibiotic usage. This is overall antibiotic usage, which was rising, and that is a national phenomenon because of increasing antimicrobial resistance and hospital-acquired infections. And then at the time of intervention, you see a sudden decline in total antimicrobial use, and we broke that down by antimicrobials for Pseudomonas, by antimicrobials for MRSA, and by antimicrobials for C. diff. And you can see, some trends downward for all of those as well, where they had been going, some of them had been going upward until the intervention. So overall, just to kind of wrap up as we're kind of coming to the end here, some general themes about how to implement a stewardship program. So of all of the examples and everything we've told you thus far, unfortunately, antimicrobial stewardship is not something that occurs naturally and on its own. It does require resources, and that may include contracting for outside help if needed, especially if in order to get some of that expertise. Right? It can be, well, it doesn't have to be a full-time person, but just having that additional help can be really useful. Time and time again, the cost of that additional resource input is consistently offset by the cost savings that comes from using less antibiotics. Plus, you get to see lower rates of C. diff, potentially decreases in your resistance, and you are improving patient safety. And lastly, just remember that overall, there can be some really small interventions that can have a really big impact with your antibiotic prescribing overall. So it can seem like this insurmountable barrier to climb, the idea of having an antimicrobial stewardship program. But if you put one foot in front of the other and start small, you can build upon what you've done and therefore eventually become, having a full integrated antimicrobial stewardship program. Right, so I just want to give a quick plug for our next session, which will be on April 25th. At this point, we are going to discuss an approach to the patient with a suspected UTI. And at this point, I'm going to open the poll just to revisit, based on the strategies that we've discussed today, do you feel that these strategies are A, feasible in your facility, B, not feasible in your facility, or C, already being used? And Jennifer, if you could open up the polling question one last time. Jennifer, I'm not sure, I'm hoping you're still on the call, but if you could just open it up to say whether or not the strategies from today's webinar are either A, feasible in your facility, B, not feasible in your facility, or C, already being used.
Emily or Jennifer, are you on the line? Shira, unfortunately, they're not on the line. Would you like to move forward?
Okay, that's open. And while people are answering that, we can just look at the chat and also ask people to go ahead and put some questions in chat during the poll, and we can kind of take a look at that. I see people saying, kind of what are the resources, where can we get started, programs for certification. There are programs for certification. The one that I would recommend most highly is the SHEA, Society for Healthcare Epidemiology of America program. They have an annual meeting, and it's actually next week. And it is certification for stewardship in long-term care. And I don't know if, Carrie, if you have any other recommendations for certification programs. That's the one I know best. Okay, so we see now some really good numbers here in the poll on the feasibility in your facility. So thank you so much for participating. And we just have a couple of minutes, and we're happy to open up the phone lines for verbal questions. I see some chat questions here. While you're unmuting people's lines, I can answer some of these questions. They're moving. Okay, so we're going to talk, guidelines. So general antibiotic use guidelines. The best place to find those guidelines is the Infectious Disease Society of America website. It's www.idsociety.org, and there's a guideline section. Every guideline really that we would recommend to be used for decision-making about treatment is on that website. I would not, if that is easier to navigate than the CDC website for those things. I do see a question about probiotics, and we get that question every time. And, probiotics, the research is very, very difficult to navigate. Every probiotic study that's been done has been done with a different dose and a different formulation. So it's hard to make any recommendations about using probiotics. Certainly for stewardship, studies are ongoing about probiotics and multi-drug resistant organisms, and they have been inconsistent in their results. So the best use I can tell you for probiotics would be to prevent antibiotic-associated diarrhea, but not really for prevention of C. diff. So that's the best answer I have for you on that. Other questions?
How would we detect if when the urine is colonized? How do we know?
So the most important concept with respect to treating a suspected UTI, and we're going to talk about this for a whole hour next month, is that if a patient is asymptomatic, that's called asymptomatic bacteriuria. That is not a UTI, and that does not need treatment. But we'll talk specifically about what symptoms are, because mental status changes are not symptoms of UTI. Cloudy urine is not. Urine that smells different is not. So it's really specific symptoms that are specifically referable to the urinary tract should indicate the need for treatment. And anything else is called asymptomatic bacteriuria and can occur in 50 to 80% of elderly women. So actually a positive urine culture is what you expect from these patients, and that does not require treatment. And we'll talk about how that applies to colonization of the respiratory tract, to colonization of a wound, et cetera. So that's really, really important and a great way to decrease antibiotic resistance. Other questions?
That's why we don't give everybody. Right.
Shira, we are over 12 o'clock. Just wanted to let you know that. And if you have any other questions and are not addressed, we will make sure someone gets back to you. Let's see. So I have a few last announcements before we end today's call. Shira, can you please pass me the ball?
Right. Sorry about that.
Oh, don't worry. That's okay.
Don't see it, Lazy.
Yep, perfect. Nope, not yet. You need to pass it to me.
Oh, we sent it to a WebEx host.
Oh, okay. So we're not able to go next. Well, thank you all for joining today's webinar. As a reminder, we are now on social media. Visit us on Facebook, LinkedIn, and YouTube. England QIN-QIO welcomes your feedback. Please complete the evaluation at the end of the webinar. The link to the evaluation will also be shared via email. Today's presentation is available on our website, and within the next few business days, a recording and transcript will be posted. Thank you so much for attending.